You get the idea with the slides, you know where we are. Um, and then I'll give you the scoop on where we're going to be for next week. All right, so this is inflammation, guys. So the review from either level 1 or previously learned knowledge. What is the definition of inflammation? Oh, it's going to be a long 2 hours if y'all don't answer me, because I'm not going to answer all these questions. You're just going to have to go at it on your own. So come on, what do you know?
It's the body response to like damage or injury.
Good. Okay. And it's an adaptive response to what the body sees actually is harmful, such as allergens, illness, or injury. Spot on. Okay. So is this adaptive response or the inflammatory response, is it normal?
Yes.
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 Okay. Where did you learn about, besides inflammation, where did you learn about the inflammatory response or inflammation?
Infection.
Okay.
Tissue integrity.
There you go. Tissue integrity, how wounds heal. The inflammatory process is integral. You know, that's the first part of the puzzle before granulation and all that starts to occur. Okay, so all of these allergens and things that the body sees as harmful, that could be physical agents, chemical agents, microorganisms, allergens. Okay, ooh, that was loud. So what are the 6 signs and symptoms of inflammation?
Heat, induration,
Redness.
pain, edema, redness.
Mhm.
The
Pain.
exudate, is that the 6th?
Yeah,
Yeah.
also exudate.
Okay, but you mentioned one, didn't give me the other. Induration. Induration is a hardened area, okay? And the organs that are inflamed do not get hard, okay? That's very specific. Induration would be like a bee sting or a mosquito bite, where it causes, it causes that inflammatory response in a very small area, so that the edema and everything is right there and becomes a hardened area. Where else might you see induration?
TB test.
Yes, the Man-2 test, PPD test for tuberculosis. There's going to be, induration in the middle and then redness around. Okay? So that's where the induration comes in. But the big part of this is functional impairment. Okay? Is the functional impairment of these organs and these systems through disease processes. All right? So if I cut my finger, all right, the first thing I'm going to do is what?
Wash it.
Ouch.
Okay, first I'm going to say ouch, which
Oh.
is going to denote what? Pain, right, from tissue damage. Okay, and then what else is going to happen with that cut?
You start bleeding.
It's going to bleed. So we're going to have to hold some pressure or whatever there for just a couple seconds and get it to reach homeostasis, right? And the bleeding stop.
Mm-hmm.
But then you notice that what starts happening surrounding that paper cut is what? We said pain,
Redness.
redness,
Heat, swelling.
right, all those things, edema, warmth, okay? So pain comes from the tissue damage, and one other thing that we'll get to. The redness or erythema comes from the increased blood flow to the area, as well as the warmth, the increased warmth or heat to to the affected area as well. And not only the increased blood flow, but the dilated blood vessels. Okay, so that body heat comes right up next to that injury. And then edema, okay, happens due to the increased vascular permeability that leaks fluid, okay, proteins and leukocytes at the site, like histamines, kinins, prostaglandins, okay? So where does the fluid leak into?
The tissue outside of the vessels.
Okay, which is where?
The interstitial spaces.
There you go, the interstitial space, where it's not supposed to be, right? So as that fluid accumulation increases, okay, it causes more pain, okay, because it starts putting pressure on that damaged area, all right? But with the edema too, the blood flow slows in those dilated vessels and could result in perfusion issues. Remember when I was talking about test taking and study skills and the number 2, right, that we use all the time? So 2 finger breaths in a cast, okay? Make sure that the cast is not constricting the blood flow, because if there's too much edema, okay, it's got what? A finite amount of space that it can swell against as far as the cast goes, right? So then you're going to see your fingers, if say like it's in your arm, fingers are going to look like sausages, and they're going to end up, turning blue or mottled. Capillary refill is going to slow. And instead of feeling warm like the rest of your body, it may feel cold or cool. All right. So all of that spells impending disaster. You also see that in compartment syndrome when people get shot or stabbed through a muscular part of their body, and the swelling takes place within that muscle. And so they have to cut open that muscle to allow those blood vessels to be able to function and perfuse the area. Same thing with the cast. It needs to be cut down so that, and you'll see, usually they start cutting on one side, they cut a little bit on the other side, and all you hear is, poof, and that cast comes, and all that's holding it there is some cotton, and they have to tape around it, to hold it in place. But, there's a finite amount of space there. So if the swelling can only go so far out, it's going to go in and compress those arteries and those veins. So we have to make sure, that no more harm comes, and that, with the edema, we keep what? Elevated.
I don't know how you do it. I swear to God.
Somebody want to mute? And then the functional impairment of the body part or system. Is the functional impairment has to do with the edema and pain.
Looking out.
And then exudate, right? Okay. So exudate is the fluid that escapes from blood vessels, as it can be dead phagocytic cells and dead tissue cells as well. All right, so stages of inflammation, we kind of touched on that with the homeostasis, and as it goes through the vascular and cellular response, and then the exudate production. So what kinds of exudates are there?
Serous.
Sanguinous.
Sanguinous.
Virulent.
and purulent. Good, 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 good. So what does serous look like?
Bloody.
Clear and
No, you're thinking of another one.
Oh yeah, I'm sorry.
Clear, thin, and water.
Yeah, clear, watery, thin.
Okay, so clear, thin, possibly, like a straw colored. Okay, but you can see through it. It's clear. Okay. Sanguineous is what? There you go, Stephanie.
Bloody.
There you go. Comes from, it's blood from ruptured blood vessels. So it's going to be red and thick. Has anybody seen, well, I'm sure you have, tubes of blood being drawn from yourself and they set them down, or from family member? And what rises to the top?
The clear.
The serous part of your blood, and then the cells and all those other things go to the bottom, right? Red blood cells and stuff. So that would very much illustrate serosanguinous as it separates. It's not going to be pink. Pink means that those red blood cells have gotten damaged and they're lysed. They're destroyed. And so that's either proper, improper, obtaining of the blood sample, or it could be a very disastrous infection process. Okay.
Can I
So,
clarify that? So are
sure.
you saying that serosanguinous or sanguinous is just blood? It's just like when
I
you're bleeding?
said sanguinous is blood from ruptured vessels, red and thick. Serosanguinous has the two parts, serous part, and then it has bloody components. Could be, clots. It could be, blood that is just separated from the cells and into the serous part. So a lot of times, when you first see, especially if they put drains in after a surgery, it's going to be bloody, right? Due to those freshly cut, skin tissue damage, and then the blood vessels. So it's going to be bloody. And
Okay.
then, over the next day or so, you're going to see less blood, okay, and more serous fluid. Okay. And the serous, contains all those great things, the, proteins and fibrinogen and all those things that are needed to, clot that injury, keep it from bleeding, and also nourish it to heal. Okay. And so then purulent. I'm so glad nobody said what?
Pus.
Us.
Us.
Pussy. Okay. That, we'll talk about that in a minute. Purulent normally indicates the presence of infection. What does it look like?
It's very yellow and you can't see through it.
Okay. It's opaque. You cannot see through it. Okay. But it can range in color from white to tan to yellow to green, okay, and to brown. It can run the gamut. I haven't seen hot pink or blue yet, but definitely that range of colors. Is it real? You're going to chart. Is it thick? Is it thick and mucousy like, or is it just some thicker, runny kind of stuff? Does it have an odor? Is it malodorous? Like, you know, need some Vicks or something to combat that. And then how much of it? Is it a little spot? Is it a minimal amount? Is it copious to where it's soaking through the gauze and all, the dressings and that kind of thing? Or how big is the stain for the purulent drainage on the dressing? Does it have a, like so many millimeters or centimeters in diameter? the more descriptive you can get, you can't just say purulent drainage because that just doesn't say enough. You got to be able to go through the color, the consistency, the opacity, and the amount and stuff, so that it gives the doctors and anybody else a visual cue as to what they would be looking at or smelling. Okay. So, pussy drainage. Okay. When in my formal life, I was a forensic biologist. This is before DNA testing. And I used to analyze blood and body fluids and in the crime lab. And so I would analyze that evidence, and then I would go to trial to testify on what I've found with the evidence from blood and body fluids to hairs and fibers. So I know what it's like to be cross-examined by a lawyer. Okay. And so whenever I document, I have a little lawyer that sits up on my shoulder, and he's like, okay, can they interpret this any other way than what I am documenting, as far as that goes? Can they see what I'm, kind of visualize what I'm writing down? And is there any place they can go with it for misinterpretation? Well, my colleagues, when I was still working and teaching, I started out in level 1, teaching skin integrity or tissue integrity, and the inflammatory, response, and all that was, it's part of wound healing. So I was teaching documentation with the mnemonic closed. And so my colleagues like, oh, you got to use my documentation. It's perfect. You got to use my documentation. And I said, well, let me read it. And so, patient lying recumbent position, head of bed, up 30 degrees, awake, alert, oriented, watching TV, assessment of low transverse abdominal incision, approximately 6 inches long, well approximated with staples until 2 inches to the left, gaping, reddened, okay, and draining, PUSS, pussy drainage. Okay. Now, I gave the scenario to this colleague, and I say 5 to 7 years from now, okay, this patient is transferred to another area of the hospital, something happened, and this patient's going to sue. Okay, and they come across your documentation. Not that you necessarily did anything wrong, but they come across this, and so they want you to testify regarding your documentation of what went on with this patient. And I said, you're going to get up on the stand, and behind you there's going to be a screen in 500 font, big block letters, red or hot pink, that says PUSSY. And that lawyer's going to ask you to turn around and say, can you tell me what that word says? And right off the top of your head, you say what? Pussy. Okay. So then they say, okay, swear you in and everything. Can you please read your documentation from the date of yada, yada, yada? So nurse reads the documentation and gets to the very end and says, pussy drainage. And they said, I'm sorry, can you say that again? Pussy drainage. Can you spell that for me? PUSSY. Well, excuse me, what did you say that word was earlier behind you? Okay, and they lead you down the primrose lane to look like you haven't got any sense, right? No, pussy drainage. pussy drainage. Then you try and backtrack, okay, and try and make it right. And what are you doing? Digging that hole even deeper, right? Oops, sorry. Sydney, stop. Stop. Everybody can hear you. Hush. And so, you're digging that hole. So what has it done? What has that testimony done?
It's affected your credibility.
Yeah, it affects your credibility.
Okay, not just yours, okay, but because of, and the nurses backtrack and say, well, maybe I should have used blah, 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 blah. Like I said, digging a hole, and it puts in the jury's mind, well, if she did this wrong and not professional like she should, what did the hospital do? Based on other things that are presented so then, the jurors look at the hospital in a different light from its employees, and, doesn't look as professional, doesn't, anyway, so you get the hint of what's going on here. So basically what the moral of that story is, use your medical terminology and describe what you see, okay? And they can't go anywhere with it. Purulent. Even if you put purulent drainage, they still can't go anywhere with it. But you haven't described it to the best of your ability as far as what exactly is going on. All right, so can there be infection without inflammation?
No.
No.
Yeah,
Who said yes?
Karen.
Karen?
Yes.
Tell them why.
Because not all the time when you have infection, you have a fever, because sometimes your body may accept the infection, or you've been having it for so long, and your body thinks it's a normal response.
Not quite. Okay. So inflammation is a normal response, is it not? Okay, it's not, it's a normal response to healing. Has to do with white blood cells and all of these factors to go together. Okay, who doesn't have some of those factors that are involved in that inflammatory process in healing?
Autoimmune, AIDS.
There you go.
Immunocompromised.
So autoimmune disorders, they're usually in hyperdrive for their immunity, right? Hypersensitive and stuff. So what do they, it's their own body attacking itself. So what do they have? What kind of meds do they have to take? Immunosuppressants. Very good. Immunosuppressants. So it's going to definitely damper that inflammatory process, and you may not see the inflammation as, right there in front of your face as you would, prior to it going into infection. And then Mia also talked about AIDS. Okay. AIDS is what?
Immunodeficiency
Syndrome. Okay. So that is the virus, right, that attacks. HIV is the virus that attacks and can cause AIDS in an individual. And what is the major thing with those particular people that are diagnosed with that disorder?
They can't fight off any disease or infection.
Okay, but they usually don't mediate an inflammatory response because the T cells that are very prominent in fighting infection and in the inflammatory response are so low that even a TB test will come back negative even if they have TB. They may have all the signs and symptoms, and maybe just a tick up in temperature, but they may have night sweats, things like that. So even though they come back negative, if you're listening to their breath sounds and they sound kind of junky, breath x-ray is going to help diagnose, what's going on. So what about people that are malnourished? They don't have protein, what? To make those white blood cells and those cells that are needed to have that immune response, that inflammatory response. Okay. And what about the elderly? Just by virtue, everything starts slowing down, right? Thirst is, on the back burner because that thirst center doesn't come forward like it should, so they're prone to dehydration, all those kinds of things. So also their immune response or that inflammatory response is dampened as well. That's why when you see somebody, an elderly person come in from with an infection, what is the first thing that you might encounter with that person?
Level of consciousness or
There
other
you go.
symptoms?
Confusion. It's usually somebody, has gone to mama's house and she's talking out of her head, all confused, thinks that I'm her dead brother or whatever. And mama's never like that, she's sharp as a tack. So, that can be indicative, definitely, of an infection process where there really wasn't any, pain, the things that would cause a UTI to say, oh, I've got symptoms, are dulled and they don't feel it like the rest of us. They don't have those same symptoms. Okay, so we basically went over the the exemplars. All right, so what you need to know is how these are going to interrelate. What do they have in common?
Inflammation.
Inflammation?
Inflammation. What else?
Looks like a lot of GI stuff.
There you go. How about all of them are involved in digestion, and nutrition aspects in things in some shape or form or another. Okay. So yeah, all GI, very much so. So peptic ulcer disease, where does that occur?
Stomach?
Okay, good. And so where's the stomach on your body, or inside your body, should I say?
Between
In
your
the abdomen?
esophagus and your intestines?
Yeah, it's in the abdomen, but if somebody comes in and complains of stomach pain, you need to be able to know what organ is underlying beneath that to start ruling out things that the doctor may be looking to rule out as well, because you're taking a history and things like that, of those kinds of things. So
Left,
peptic ulcer, what? Go
left
ahead.
quadrant.
Okay, so the stomach starts, it's kind of bulbous a little bit, just left of mid gas, mid abdominal region, and then kind of swings around to the just to the right of midline, okay, of the mid-gastric region. And it can also involve the epigastric region as well, where what intersects? The esophagus and the stomach, right? Remember you had GERD, and so that's that lower esophageal sphincter. Okay, so what does the stomach do? What's its function?
Breaks everything down.
Okay, so you chew your food, you masticate it and stuff, you swallow it down through the esophagus, it gets to the stomach, and what does the stomach do?
Uses like acids and stuff to break it all down.
Okay, to break it down even further, and a churning action, right? To kind of act with the hydrochloric acid and some of those other gastric acids to break it down further, the fiber and all those other things that go along with what you eat. Okay, so peptic ulcer disease. If somebody has an ulcer, what might, okay, all those 6 symptoms, we're not going to be able to readily see the redness, right? Because that's an internal organ. We're not going to be able to see the edema, okay? They have complained about pain, and I'm going to, ask you about the mnemonic that goes with that, okay? So exudate, not so much, but are they nauseated? If they're nauseated and they vomit, what are they vomiting? Are they vomiting blood? Or is it bile? Those kinds of things. So you need to be assessing all the time, where is this going to go? So for peptic ulcer disease, if it perforates the stomach, the ulcer perforates the stomach, they can end up with peritonitis. All that stomach contents that is not sterile leaks into the peritoneal cavity, and that is sterile, and turns into a very messy infective process. Okay, so as the stomach churns and the acids break down the food even further, it turns into chyme. Remember that? Okay, and so it works its way down the stomach into the duodenum, where there are a variety of ducts that come in to add more ingredients, if you will, to break down food even further. So behind the stomach, part of the pancreas is just to the left of mid gastric, the center line of mid gastric, to right there at the duodenum, where at the bottom of the stomach is the pancreas, and it lays behind that. So across the back side of the stomach. So people not only can have left upper quadrant pain to some degree, it can also be, mid right, but it can also radiate, have back pain with it because of the edema and stuff and pushing on things that it's not supposed to be pushing on. Okay. What function does the pancreas have?
Production of insulin.
Production and secretion of insulin. Okay. What else? This is where AMP, rears its ugly head, guys. If AMP2, you pumped and dumped that information, you better dig out those notes or, check out YouTube with pathophysiology for some of that.
Does the
So go ahead with pancreatitis.
Does it also
Glucagon is liver.
Yeah.
Okay.
Cholecystokinin, right? Isn't that pumped into the duodenum to uh, like to I guess instill a sense of fullness, something like that.
I'm not sure kind of where you're going with that, but the pancreas has, once it just leaves or is getting ready to leave, the pancreas has potent enzymes for the breakdown of carbohydrates in the form of amylase, proteins, protease, and lipase for fats. Okay. And so all of those are enzymes that go through the pancreatic duct and go into the duodenum to be able to break down that chyme and things even further. Okay. So say, we'll get to that in a minute. So the liver is then on which side of the body? Do you know?
Right.
Right side.
Right.
The right upper quadrant, and it goes down to the mid quadrant on the right side. Okay. What does the liver do?
Filters.
Okay, it filters the blood to take out toxins, right? And metabolize some of those medications and send them to be excreted wherever they need to be excreted from. And what else?
Glucogen.
Okay, the glucagon, but going in
Doesn't it
another
make
direction.
bile? Like,
Hmm?
doesn't it make bile? For
Yes, it makes
digestion?
bile. Very good. It does produce bile and secretes it into what?
Gallbladder.
The gallbladder. The gallbladder is the storage tank for bile for the liver, for those big time fatty foods that we eat, so that it can go in there and really break down those fats even more. Okay.
Doesn't it produce what is it, bilirubin? Or excrete
So
bilirubin?
actually, yes, it excretes bilirubin, which is a product of the breakdown of red blood cells. Okay. And if that malfunction, if it doesn't secrete it where it needs to go, then, or excrete it, then it builds up, and what happens?
You become jaundice.
Patient becomes jaundice, right? Okay. So what else does that liver do?
Gonna say also the urine would be pretty dark with that bilirubin buildup.
It can be if it's excreted,
Right.
properly, but it may not be. It may just be circulating in the blood because it's not bound like it should be to be excreted. Okay, part of the function of the liver as well. What else?
Not sure if this was said, but it stores a glycogen.
Right, glycogen, yes, glycogen. Okay, but what else? And it's a big factor.
Albumin.
Okay, has to do with protein and somewhat albumin. Yeah, we're looking at albumin and total protein. And what about the fact that it manufactures or produces clotting factors like prothrombin? Okay, so if there's an impairment of function there, then what are those patients prone to do?
Bleeding.
Bleed, right? Absolutely. Okay. So bleeding. All right. So you have the hepatic duct coming down and doing what it needs to do to filter the blood and secrete and excrete wherever things need to go to be excreted even further. It secretes the bile into via the hepatic duct into the gallbladder, and then the bile duct comes out, and that's where the bile comes from. If there is, with cholecystitis, right, It can be a thickening of the wall. It could be sludge noted in there. And what else could be noted in there as well? In the gallbladder. When it's inflamed.
Gallstone.
Gallstones, yes. And it's called cholelithiasis. So it's CHOLELITHIASIS. Okay. So cholelithiasis is gallstones, and most of the time they're made up of cholesterol. All right. And what those stones can do is come down and block those ducts there. And so here comes the pancreatic duct with the enzymes. It can't go through because there's a gallstone blocking its way. So all those enzymes are then refluxed back into the organ. And with all those powerful enzymes that break down protein and fats and carbohydrates, it starts to auto-digest itself. Okay. And thereby causing malfunction. With alcoholism, it's a matter of the inflammatory process is caused by the alcoholism, and the edema occurs in the pancreatic duct to where it shuts almost completely down, okay, and then causes the backup of the enzymes for autodigestion as well, okay. So all these enzymes and bile and everything come around the duodenum. You know, if there's a gallstone in the common bile duct that blocks it, you know, that's when one sign is going to be the inflammation of the liver, and then of course the increase in bilirubin, which causes jaundice. Okay. So we talked about that. Again, refresh your memory from your physiology portion of your systems and your organs. Inflammatory bowel disease. Okay, two exemplars. Crohn's disease can happen anywhere from the esophagus all the way to the anus. Can happen anywhere in that GI tract. Okay, most notably, it is noted to run the spaces of the small intestines because there's just a lot of small intestines. It can cause blockages because the inflammatory process doesn't make the intestines slide against each other. It makes it kind of sticky, so they end up sticking. They can cause fistulas between the intestines. It can also cause, like I said, bowel obstruction. Okay, so what occurs in the going into the small intestines? You got the duodenum and stuff. So what occurs right there?
It's where you get your
Like
nutrients.
nutrients
There
are
you
digested.
go. The absorption of the nutrients, the breakdown, the lipids, the carbohydrate, the proteins, all those kinds of things, the vitamins and minerals, okay, that help us with wound healing and keeps us healthy and those kinds of things. So you can look, malnutrition is a big thing with Crohn's, fluid and electrolyte as well. Okay. Ulcerative colitis actually is specifically oriented to the descending colon and the sigmoid to the anus. Okay. And it's ulcers in that intestines. Okay. Bleeding can occur. They can have erosion for fistulas too. I've seen anovaginal fistulas where stool is coming out the vaginal area. And so that definitely needs to be repaired. So you guys make sure you know the functions. You can recognize the function of those organs so that when the malfunction happens, you know what interventions you're going to do and why. Okay. All right. So we talked about what organs are involved, where are they located, and also the 6 signs and symptoms relate to these organs as well. So usually you're not going to see the redness, you're not going to see the edema. What did you learn about GERD as far as a diagnostic test?
Endoscopy.
Okay. Probably specifically an esophagogastric, oh God, my mind just went, esophagogastroduodenoscopy. So in other words, they put a scope, okay, they put you in a little twilight sleep, they put a scope through your mouth, down your esophagus. They can visualize, the GI doctor can visualize the esophagus and see if there's any erosions or varices, redness, edema, abnormal cells can go down strictures. They can dilate strictures so that that doesn't become a problem with restricting food intake. Going down into the stomach, visualizing the stomach lining. Um, are there ulcers present? And they can recognize, is it the ulcers from H. pylori, which is a bacteria? Is it an ulcer from a steroid? Is it an ulcer from non-steroidal anti-inflammatories or like ibuprofen or corticosteroids? Okay. Or is it stress? So those are things, if they need to take biopsies, they can do it right away, any abnormal cells or whatever else they need, and then they can initiate a treatment because they've seen, more than just the pain that the patient verbalizes, okay, and then some signs and symptoms that they're talking to us about. So they can actually visualize. Okay, so general assessment for information, don't worry about the page number 676. Look, there's probably just a little section on assessment interview, but it's imperative to obtain a, a detailed patient history, especially when it comes to inflammatory processes and responses, those kinds of disease processes. Is this a new onset, or is it a chronic thing? How many years have they had it? How many exacerbations that required hospitalization? All those kinds of different things, because the more exacerbations that they have and the chronicity of the inflammatory process within that organ can cause formation of abnormal cells. And then with abnormal cells, they can, then evolve with, still the chronicity of and of the inflammation and the exacerbations of acute episodes. It can end up being precancerous and then cancerous. So all those things are important. Also, just when was like their last colonoscopy? Okay, they can do colonoscopies outpatient when the patient is in kind of a remission and they're not having acute inflammatory exacerbation of the disease process. Okay, but as far as when they come into the hospital, it's going to be CAT scan or what have you to diagnose those kinds of things, right? Like diverticulitis, same kind of thing. Inflammation within those bowels, but you're still not going to do a colonoscopy for that because, inflamed tissue tends to be friable. What I mean by friable is that it can break down very easily. So if they come up with a scope and try and push it through, the rectum and stuff and up into that sigmoid colon, what do they run the chance of?
Hemorrhaging or damage.
Find the tissue.
Okay, perforating the bowel, right?
Peritonitis.
And so peritonitis, absolutely. So, remember, everything that's in the digestive tract is not sterile, okay? Because we don't eat sterile food, okay? So all that is not sterile. But if there's a perforation and that stuff is allowed to empty into the peritoneal cavity that is sterile, okay, then you can have a world of hurt of infective processes, including sepsis. Okay. Real quick before I let you go for a break, you're going to conduct a focused assessment on the affected body system and then a regular physical assessment after you do the focused assessment. What kind of focused assessment will you be doing?
Wouldn't that be, when did it start and how long?
When you learned about those abnormal focused assessments last week, okay, you learned what? Cardiovascular, respiratory, neuro, and neurovascular, right? What's left? What are we talking about?
Gastrointestinal.
Okay, so GI or the
Yes.
abdomen,
Oh.
right? A focused assessment of the abdomen. So what is the first thing you do when you're doing an assessment of the abdomen?
You inspect it.
Inspect it.
Absolutely. Inspect it for what?
Distension.
Yes.
Uneven.
Discoloration.
Is it right? Is there anything on the belly, sores or bruising or anything? Is there, is the stomach flat? Is it concave? Is it, obese or protuberous? Could it be part of ascites where you can actually tell the fluid motion when they change position? Okay, so all of those things you can inspect.
Also, if they have
Okay,
like a bag, an ostomy bag or anything like that.
right. So anything like that, absolutely. A peg tube, all that kind of good stuff. Okay, so inspect. Then what are you going to do?
Auscultate.
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 Auscultate for sure. So you're going to auscultate each quadrant to see if the bowel sounds are hypoactive, hyperactive, normoactive, or absent, correct? Okay, so you're going to auscultate all those things. Then after you auscultate, what are you going to do? Or what can be done? What is
Palpate.
the definite, what is the definite
Percuss.
of a focused assessment? Yes, percussion.
Percuss.
We as regular RNs may not be doing it, but nurse practitioners, advanced practice nurses, as well as healthcare providers do. And so your patient needs to know what they're doing and why they're doing it. Okay, because you know how wonderful doctors are at explaining, the techniques they're doing while they're doing them, right? They just get all hands in and the patient has no idea what's going on. So they have to know, he's percussing, he's doing some, this light tapping to see about where your organs are and if they're edematous or not, and, all kinds of different things. And then after they do that, then what do they do?
Palpate.
Yes. So what kind of palpation do regular nurses do?
Light.
light
touch.
palpation. You know, nurse practitioners and healthcare providers, doctors usually do a deeper palpation. Okay. So that's the focused assessment for the abdomen. And then we gather diagnostic and laboratory data, you know, EGD, you know, and we're going to talk about the laboratory data when we get into um, the exemplars, as well as when I get you back from your break, and we'll talk about some laboratory testing. So you guys take a 10-minute break, come back at 25 minutes to 12. Thank you. Oh, if you haven't signed in, please do. Okay, it's like mandatory. I like only have a few people in chat. All right, y'all, I'm ready to get back started. So one of the things that I wanted to tell you when you are talking to your patient about pain, anybody heard of the mnemonic PQRST? Okay, very easy to remember, so that when somebody's complaining of pain, you think of, okay, so P is going to be position as to where is the pain, where's the pain located. Is there any position that makes it worse? Any position that makes it better? Okay. Q is going to be quality of the pain. Okay. Exactly what is the sensation of the pain? Is it stabbing? Is it dull? Is it aching? Is it throbbing? Is it gnawing? Is it burning? All those different kinds of adjectives. Okay. So is it a slow onset coming on, or is it abrupt, like all of a sudden pain? Okay, R is radiation. Does it radiate to anywhere, any place else? Okay, with the gallbladder, where it sits, okay, because of the edema and inflammation, it can radiate to the back and like behind the scapula, okay, on the right side, and cause radiating pain there. S is the severity scale, okay, 0 to 10, right? And what is their pain goal? And also, if they can't do the numeric scale, then the facial, the faces. And then T is timing. Okay, when did the symptoms start? Do they happen a certain time of day or night? Is it before eating or after eating? Does, again, is it a gradual thing, or does it come on abrupt, as far as, is it when you sit a certain way or lie down a certain way? Exactly what is the timing? Okay, so PQRST. So now we go to diagnostic and laboratory testing. I mentioned the esophagogastroduodenoscopy before, an EGD. Anytime you're going to have, the patient's going to have an outpatient procedure, or an inpatient interventional procedure. If there is a bleeding ulcer, the patient is experiencing a bleeding ulcer, they now, instead of having surgery on the stomach itself, they will go in via the EGD and clamp, put a little clip on that ulcer to close it and have it stop bleeding. Okay, so that'll be interventional. But as far as diagnostic, outpatient, the patients have to be afebrile and have stable vital signs. Okay, so that if something, when they come out, they have something abnormal going on, okay, then like now they have a temperature, they had a temperature of going in of 98.2, and now it's 100.4 after the procedure. Well, something happened. Now we've got to figure out what's going on. Okay.
Wait, so can you
So
say they can't have a fever and they can't have what?
They can't have a fever. Their vital signs have to be stable for them.
Vitals.
Yeah.
Okay, thank you.
Yeah. So, and same with an outpatient colonoscopy. They can't have any inflammatory, symptoms or exacerbation symptoms with that, because it can cause a perforation. So, two blood tests that are diagnostic for inflammation. Okay, ESR is an erythrocyte sedimentation rate, or affectionately termed as a SED rate. Okay, that is not on your lab values. So it's coming from me and from the book. Now, The sed rate measures how far the erythrocyte settles in a tube over 1 hour. Okay. They say normal for males is 0 to 15 millimeters per hour and females 0 to 20 millimeters per hour. I'm not going, 5 millimeters really. So, and if there's an inflammatory process going on, it's going to be way up above 20. Okay, so anything above 20 millimeters per hour, okay, is going to be indicative of the presence of an active inflammatory process going on. The red blood cells stick together and settle faster, causing a higher reading. Okay, so I'm not going to give you a sed rate of 22 or 16. No, it's going to be 50 or whatever. It's going to be pretty much in your face, but what are we going to do about it? And I'm going to talk to you about that in just a sec. So C-reactive protein is the CRP, and normal is less than 1 milligram per deciliter. Okay, so anything 1 and above, again, is in response to an inflammatory process. Okay, so usually CRPs are, again, if they're going to be positive, they're going to be way positive for the inflammatory process. So what do these 2 laboratory tests tell you?
Something causing inflammation going on.
Okay, so it's non-specific as to where the inflammation is, but it definitely tells you how severe the inflammation is within the body. Kind of like how hot the fire is, just not where it is. Okay? So that's what these things tell you. And they usually get these upon initial entry into the hospital, again, to see, of the inflammatory process that's going on within an individual, especially if they can't put their finger on like infection or something like that, but they're having all these signs and symptoms. They'll do, a sed rate or a CRP and say, there's a lot of inflammation going on in this person's body, but we just need to keep looking to see where it is. Okay. Now, CBC with differential. CBC, you're going to have to memorize cold. Okay. White blood cells, 5 to 10,000 per millimeter cubed. Boom. Okay. That's what's on your sheet. Okay. So
Do we need to memorize?
CBC.
Okay.
Okay. White blood cell count. Not so much red blood cells as the doctors usually want to know the hemoglobin and hematocrit. And like I said, if you can just measure or memorize the hemoglobin, the hematocrit is going to be the value 3 times that number. Okay, so say your patient's anemic, has a hemoglobin of 9.5, okay? And so hemoglobin's 9.5. What would you expect the hematocrit to be?
27 or
27?
28.
Okay, somewhere in there. Okay, so you got a ballpark figure of where it should be. All right. And usually that's where it is. So hemoglobin and hematocrit. And then there's platelets. Platelets, tell you, right, how good the clotting mechanism is in the patient. But with chronic inflammatory disease processes, okay, and the longer the inflammation goes on, their platelet count for some reason goes up and up and up. And I've seen it upwards of 800,000 to 1 million. Okay, and the norm is 150 to 400,000 per millimeter cubed. So what does that tell you? What do you need to make sure that's going on with your patient?
Have routine blood work or blood work,
What kind of blood work?
CBC. Or
CBC gonna, I mean, yeah, you want to trend the platelet count, but what would that amount of platelets, what
So we
is,
want to make
I mean,
sure
it's
that
gonna
they're
like
not
clog the
clotting.
arteries, right?
Yeah, like
not clot the arteries?
embolism?
You're on the right track. What
Mm.
happens before an emboli, usually?
Blood clot.
Where?
is it a DVT?
There you
Oh,
go.
Oh,
DVT.
okay.
DVT in the lower extremities, usually, right? So that's why we have you in assessment compare one leg to the other, because usually a clot's not going to happen in both legs. One will be edematous and reddened, and things like that, and you compare the two legs, okay? So they need DVT prophylaxis. The TED hose, the sequential compression devices, the SCDs, or the plexi pulses, along with anticoagulant therapy. Okay? So those are real important. The differential, yes.
What was the normal hemoglobin?
It's on your lab value sheet, and it's 12 to 18 grams per deciliter. And then hematocrit is measured in percent. Okay, so the differential, your clinical instructor will probably have you know those because you might be looking at those in clinical and they want you to trend those kinds of things. All right. And we'll get to specific lab work when we get into the exemplars. Something else that we need to do, is find out what the actual problems are for our patient and then what the risks are, the potential problems or complications. Okay. And then prioritize. Actual comes before risk, ABC, airway, breathing, circulation, level of consciousness, okay, pain, all those kinds of things. Remember your Maslow hierarchy of needs, so all those kinds of things, and be mindful of those complications. Be mindful of those. So with PUD, you can have just an ulcer that causes pain. You can have a bleeding ulcer that hemorrhages either by vomiting blood, or if the ulcer is lower, then it's going to pass all the way through the intestines. Okay, digested blood is called melena. It has a specific odor. You will not ever forget a GI bleed. Okay, the stools tend to be black and tarry, and then if the hemorrhaging continues, it can end up being red and gelatinous, just like congealed blood. Okay, so be on the lookout, and then if not only can it bleed, but you can have a perforation and end up with peritonitis. So, which is, going to infection, and that person needs to be taken to surgery. So planning, with goal setting for your patient. Okay, goals can be short-term or long-term, things that happen within a week or 2 weeks, and then what you want to see happen by discharge. They need to be patient specific, okay, realistic, measurable, and achievable within that given time that you allow it. Okay. Maximum 3 expected outcomes. You know, if you have somebody that, say, infection, because that's my other lecture and it's just easy. You know, if they have, they come in with a white blood cell count of 22,000 per millimeter cubed, the norm is 5 to 10,000 per millimeter cubed. Okay, that would be a specific measurable outcome. Okay, and the intervention would be to monitor, you know, the CBCs as ordered for white blood cell count. Okay, so it fits all those specific things, you know, and you're going to want a trend. You know, are the white blood cells going down with antibiotic therapy, or are they kind of stagnant, hanging out at 22, and then maybe going up? And then you're seeing other signs and symptoms of maybe organ failure that you didn't, you know, like low urinary output and, you know, decreased level of consciousness or confusion, things like that. So you definitely want goal setting for your patients. If you're talking about ambulation for the patient, you know, it's got to be specific, measurable, so that if you hand your care plan to the person sitting next to you and say, here's my care plan, you need to take care of my patient. Okay, you should be able to know what interventions to do at what time for that specific patient and what those outcomes are supposed to be. You know, for ambulation, activity tolerance. Maybe you're saying, you know, in 1 week, they should be able to walk from their door to their room to the nurse's station without shortness of breath. Okay. And a pulse ox of 95%, which is normal, right? Okay. And then maybe by week 2, they can go walk from their room to the nurse's station and back to their room the same kind of way. Okay, so those are those kinds of, you know, another thing realistic, specific to that patient. Maybe they need a walker. Okay, you don't use assistive device. That doesn't tell the nurse anything that's taken over your patient's care. Tell them what kind of assistive device they need to be using. So interventions and therapies, okay, for injury, you're going to reduce the mobility of the involved area. Okay, sprains, strains, broken bones, all that kind of stuff are going to be in, you know, immobile for a while to let those areas heal. You're going to have the patient elevate whatever extremity or whatever's wrong. Okay, so that the edema reduces wherever the edema is. You can give antipyretics, PRN. What's an antipyretic?
Anti-fever.
Fever.
Right. Fever reducer, right? So what kind of drugs can be fever reducers?
Tylenol,
I
ibuprofen.
don't know. Advil.
Right. Ibuprofen, aspirin, those kinds of things. Okay. What about anti-inflammatory medications?
Steroids.
Okay, corticosteroids. So, okay, so the NSAIDs, definitely anti-inflammatory medications. Steroids, they are severe systemic anti-inflammatory. They're for severe systemic inflammation, and they are, you know, the top rung of anti-inflammatories. What are some of the side effects of corticosteroid therapy?
Decreasing the immune system.
High blood
Okay,
Pretty high
sugar. High
infection.
blood sugar.
okay, increase in blood sugar for sure. Okay, which might be extremely problematic if the person has diabetes as well, right? Um, and so, let's see, what else did you guys say? Blood sugar, what else?
Weight gain.
Weight gain from what?
Fluid retention.
There you go, fluid retention, absolutely. Okay, that could be problematic for a patient with what?
CHF.
Yes, what else? How
Urinary
about
problems?
how about hypertension?
Yeah.
Because if the patient is not excreting the water, it's circulating in the vasculature, or it may be dependent edema, but if it's circulating in the vasculature, it's going to raise the blood pressure even higher. So surgeries, you're going to be doing surgery for things, or you might be, the perioperative nurse there for cholecystitis, cholelithiasis, taking the gallbladder out, or ulcerative colitis and the formation of a man-made fistula, which is called a colostomy. Okay. Antibiotics for inflammation caused by infection, and then dietary support. All those healing mechanisms of vitamins and minerals and those kinds of things for healing, the increased calories, the protein that needs to be present for those white blood cells and things to be able to be made. Okay, so you get the healthcare provider on board to get the dietitian or nutritionist to check out the patient, possibly do a calorie count, also the percentage of food eaten at each meal. So if they're not eating big meals, maybe they need 6 smaller meals, or some kind of supplements in between, Ensure, or those kinds of things. And of course, more interventions. You want to prevent further injury. Like I said, you don't want the physician to say, "Oh, I'm going to do a colonoscopy," and you're like, "Excuse me, but my patient has an acute exacerbation of ulcerative colitis." That's not, best practices, because perforation can occur. And that's where these team steps, communication techniques come in. Assist with activity as ordered, if they have to ambulate 3 times a day. Increasing mobility increases motility. Okay, so bed rest, decreases peristalsis, along with any kind of opioid, analgesia, and all that kind of stuff, can put the patient for complications of constipation, right? So we need to be on top of that before that even happens, by having the healthcare provider order stool softeners, maybe once a day, maybe twice a day. They may even order Miralax as well. Assist with hygiene and ADL's PRN, activities of daily living. OT and PT may be consulted. OT is occupational therapy and has to do with what? Does anybody know?
Yes,
Like
fine
feeding
motor movements.
yourself or
Okay, so what, Ryan?
Yes,
What'd you
I
say?
said fine motor movements.
Okay, fine as well as gross motor movements of the upper body, strength, and being aware, especially if they have had a stroke or something that slows their movement, or now they can't feel like where their extremity is in relation to their body. So they have to learn how to brush their teeth and wash their face and brush their hair possibly feed themselves with a modified silverware to be able to get the food there. And then PT has to do with what?
Movement, physical therapy.
Physical.
Okay, so strength and coordination and balance of the lower extremities, focusing on gait and, being steady. And, if they need some kind of assistive device to help them be safe when ambulating, those kinds of things. We also want to alleviate discomfort or pain. Some people think that if it's sore and it's an intense sore, that's not really pain, but it is. And so sometimes you just need to sit eye to eye with your patient and say, what kind of problems did you have yesterday and last night? Because let's focus on those to get you feeling better and more like yourself. And you'd be surprised just going through those problems in the plan of care with the patient. They know right what they're supposed to be doing and what you're going to be doing for them and stuff. And, if you tell them why, they will comply. Okay. You just have to tell them what you're doing. But alleviating discomfort, again, like we were talking, with the opioid crisis, physicians now have to, they have to justify having a prescription for opiate pain medicine longer than 7 days after a surgery. That's why they have started with healthy middle adult age people that have, appendectomies or cholecystectomies or whatever, they're having, and they have, not a lot of comorbidities like hypertension and diabetes and all those kinds of things. They're going to the anti-inflammatory drugs, the NSAIDs. So in between, you may be only able to take the opioid and opioid analgesic for every 6 hours, but in between, every 6 hours, you can have 200 milligrams of ibuprofen or naproxen or whatever they've ordered to be able to have more of that stability of not having those big ups and downs of pain relief and then way up here with pain, so that it's more of an even keel and the patients can do more and participate in their own healing process. You want to help promote coping, address their feelings. Avoid using the why word. Why are you feeling like that? No. You address what you see, that you're concerned if they're crying or whatever, that you're here for them. Maybe there's something that you can do. Social worker, maybe they don't know how they're going to pay their hospital bill. Stuff like, they don't have sick leave, so they won't have a check coming in. That you can't do anything about, but you can, they're, the children can only be with this grandparent for so long, and then other people are going to have to help with, bringing with childcare or bringing them back and forth. You just try and not let it overwhelm them, and have them, take one thing at a time and fix it, and that kind of thing, and decrease stress. Stress can cause the hypersecretion of the hydrochloric acid, which can then cause ulcers. Okay. So, you might see your patient on a proton pump inhibitor, which is going to decrease acid production and secretion. And they don't have history of GERD or a history of PUD. It's prophylaxis so they don't get an ulcer. Okay. More interventions and therapies. Again, we talked a little bit about the pharmacological reducing the inflammatory response, the NSAIDs. Another thing the NSAIDs can do, ibuprofen and stuff, again, is cause the patient to retain some fluid and thereby increasing blood pressure and increasing, water weight. Also it makes the platelets a little slick, right? So that it's an antiplatelet aggregator. So it helps them not to clot, which can work in your favor, can work against. So when these physicians now are trying to work out their plan of care for pain control and inflammatory response control, they're looking at the benefits and the risks and weighing them out. We talked about glucocorticosteroids, opioid analgesics. So what else about opioid analgesics? We talked about constipation. What other side effect?
Safety,
Hmm?
like safety issues.
Okay. One of the side effects is sleepiness. Besides, you want the pain relief, but sleepiness. So right after it starts taking effect, you may not want to get them ambulating right at that time. Let them rest a little bit, and then, while the pain medicine is still in their system, then get them to ambulate when they're, more awake. What else about the opioids?
Addictive.
What, Allison?
It can slow your breathing.
There you go. Decreased respiratory function. It slows the respiratory rate and also makes it more shallow. Okay, so that's why it's so important, especially after surgery, that you have them turn, cough, and deep breathe through the night. Yes, it's, every 2 hours you're going in there and having them turn, splint with the pillow, especially if it's abdominal surgery, hold it close so that they can take some deep breaths and elicit a good cough, not just but a good kind of thing, so that it expands those alveoli and you don't have the atelectasis and the secretions that start migrating and stay in one area and can become infiltrates and precursors to pneumonia. Okay, so you definitely want them to turn, cough, and deep breathe every 2 hours. In the morning, have the doctor write for an incentive spirometer for teaching, and then during the day you can remind them about the use of that to help prevent atelectasis and expand their lungs. So natural therapies. What are some natural anti-inflammatories, such as I don't know. People take capsules full of them for their anti-inflammatory. Turmeric. Okay. Cinnamon is another one. Okay. What about cannabinoids or cannabinoids? Okay. Called CBD oil. And the CBD oil has the THC, or the part of the plant removed that is the drug that causes people to be stoned, okay, and altered perceptions and have the munchies and all that kind of good stuff. The CBD oil, it relieves anxiety and has antidepressant properties, reducing the risk of arterial blockage, relieves pain, also is a potent anti-inflammatory, and protects the neurodegenerative or helps with the neurodegenerative disorders, so that it protects those nerves and help them still function. Okay, so one of the things that we as nurses have to make sure is, are they taking these? And then are the family members bringing them from home and they're taking it on the slide because they could interact with other medications that we're giving them that may be an adverse reaction, and we want to protect them from harm. Okay, so we want to definitely evaluate what we're doing, you know, the goals, were they met, were they not met, were they realistic enough and in the proper time period, you know, given, and then were the interventions, were they effective in reaching those goals? Okay. And in looking at them, you may have to modify the goals, the time period, or and step back because, you know, they may have had they had some progression and now they're having some regression in their, you know, in achieving those outcomes. And then again, modifying interventions is needed for the best interventions to get the patient towards those outcomes. And last but not least, we talk about nutritional therapy, parenteral and enteral. What is
Can't hear you.
You cut out. What'd you say?
parenteral nutrition?
Through this, like through a needle or like a
You're on the right. Yes. Okay. It's nutrition given through IV access. Okay. And what we talk about is TPN, total parenteral nutrition. Okay. It can only be given through a central venous catheter. Okay, you've heard of triple lumens and stuff in the subclavians, right or left, in the internal or external jugulars and femorals as well. Okay, the TPN has a specific mixture of amino acids, high percent of glucose, and electrolytes and minerals. Okay, so it is a haven for bacterial growth. Okay, so once 24 hours has occurred, and even if the bag's not, you know, half empty, whatever, okay, that whole bag and tubing comes down, and two nurses read and make sure the TPN is correct. They spike the bag, and the nurse goes in and plugs the TPN in. You're going to make sure that that central venous catheter or what other kind of line is a central catheter as well. You learned about a PICC line?
PICC line?
PICC line. Peripherally inserted central catheter, okay, line. And both of those are inserted via sterile technique. And the lumens are, you know, fed through the vessels and into right before the right atrium of the heart. Okay. And so they need to be positioned properly before use, and they need to be confirmed by x-ray. Okay. Some complications that can occur when somebody is inserting a central venous catheter, say to the subclavian, you know, a pneumothorax. Okay. They can have improper positioning where the catheter is not where it should be. And then also brachial plexus injuries, nerve injuries, you know, in the arm, which can cause nerve pain for the rest of that patient's life. So we want to make sure that we check the site for signs and symptoms of infection. Lipids are usually given, so fats are usually given 3 times a week, Monday, Wednesday, Friday, Tuesday, Thursday, or Saturday. They are hung, they can be on the same IV pole, but they have their own separate pump, okay? And this is the only thing that can be, quote unquote, piggybacked into TPN, but it has to be piggybacked to the port that's closest to the patient. Okay. So there's usually only this, usually only this much that is actually mixed. And so what, Callie, you said?
Wondering why that was.
Because the lipids, it comes with its own vented tubing. It's usually a glass bottle. It has its own filter and stuff. Because think about fats. They have like a coating on them, right? I mean, they're slick, lipids are. And so if you put it throughout the whole TPN tubing, okay, it's going to leave a film on that tubing that is not good for the initial TPN mixture. But at the very end, it's not going to make that much difference. You just don't want a whole tubing that can then be compromised for the TPN to flow.
Okay, yeah, thank you.
Does that make sense? Okay.
Yeah.
So if it's got a high percent of glucose, what do we want to check on the patient?
Blood sugar.
Good. Blood sugar via glucometer every 6 hours. Okay, every 6 hours. So with this high concentration of glucose, anybody with a normal pancreas, the pancreas will then rise to the occasion and secrete the amount of insulin needed to put that glucose in the cells. Okay, problem exists when then the healthcare provider discontinues the TPN. Okay, and usually when they're able to eat something and start gradually put things in their stomach. But, say like breakfast is come and gone and they now discontinue the TPN, you can't just pull it and flush the lumen and be done with it. Why?
The blood sugar would drop too much.
There you go, because pancreas is still secreting this much of insulin and the glucose has dropped right out. So you're going to decrease it and measure the glucose over the next few hours till you can totally, discontinue it. And then an hour after you totally discontinue it, you're going to take one more blood sugar to make sure that their body's handling it well. Okay. All right. And those lumens are going to be flushed. The ones that do not have anything running through them are going to be flushed with 10 milliliters of normal saline, and then usually 3 milliliters of heparin to keep the lumens patent. So enteral feedings, I know we got a few minutes. So for parenteral feedings, who do you think would be getting the TPN through the IV?
People who can't swallow.
Unconscious
No.
Nothing by mouth.
The PUDs, right?
Okay. Nothing by mouth is different from can't swallow. Okay. Nothing by mouth on bowel rest. Okay. Your ulcerative colitis, possibly the PUD, but usually those, unless they have to do a gastrectomy or whatever, then yes, if it's going to be on bowel rest. Ulcerative colitis, Crohn's, all those kinds of pancreatitis, where those enzymes are secreted, but, everything has to be shut down in MPO and on bowel rest for the inflammation to resolve itself. So IV is the best way to go. Okay, so it's usually anybody that needs bowel rest or rest on the GI tract. Now, for those that are having difficulty swallowing, say, liquids or food, and they're coughing through all of that, and you're afraid they're going to aspirate, okay, then, you would put them NPO and tell the healthcare provider what's going on, and they would then order a consult with speech therapy for a swallow study. Okay, so there's nothing wrong with their gut. They just can't get the nutrition into the lower gut to be, right, to be utilized for nutritive purposes. So what they would do is put a nasogastric tube down, which will go in an air and down the back of the throat into the stomach, okay, for tube feedings, but need an x-ray for confirmation for that as well to make sure it's right where it needs to be. Or they can have a percutaneous endoscopic gastrostomy tube or jugostomy tube. Okay, so a PEG tube that goes right into the stomach via interventional radiology. They go through the skin, through the stomach lining, and suture that in, okay, and make sure that's patent, or into the jejunum with a jugostomy tube, okay. The big thing there is, again, placement with the NG tube. Why? What can happen? What kind of complication with the NG tube if it's not
Or
confirmed?
into the
It
trachea
can go to
instead
the
of the
lungs.
Right, it can go into the lungs.
And that can
Yes.
cause pneumonia.
Oh, yeah, it can cause a world of hurt. Absolutely. So a lot of what we do for placement for the NG tubes now is when they're inserted, they mark where the insertion point is, like 20 centimeters or whatever it is, to where it's supposed to be, okay? And they tape it. So, and it's charted so that, you know, when you come on, if it's sticking out, you know, this far, if you try and push it back, you know, you're going to have to get another x-ray to make sure that it's where it needs to be again. Okay. So that kind of thing, because you can't just take for granted that when you check a residual, which means you pull back and aspirate, okay, stomach contents from the tube, it's like, where in the stomach are you? You know, are you at the very top? Or are you at the bottom, in the middle, wherever you're, you know, it needs to be where it needs to be. So part of that, you know, when you get the aspirate, you know, are you getting bile? Are you getting some tube feeding that looks like it's been partially digested? Sometimes if you have resistance, that means that stomach's emptying like a charm and you don't have a problem with it, and that the aspirate is nothing, or the residual is nothing. Best practices tells us that we should be using litmus paper to when we withdraw the residual, and to put on the litmus paper that aspirate. And if the pH reads less than 4, then we're where we need to be in the stomach. Okay, but litmus paper is expensive. Okay, so our hospital's willing to put that out, and it's only as good as the nurse that uses it for their patient. They may end up leaving it in the room. Then all these people come into the room for the patient. They don't know what it is, and it ends up in the garbage can or stuck in some drawer in the back. Okay, or the nurse takes it home with her, never to, you know, bring it back to the nurse's station. So all of those things precludes us from having those types of best practices in the hospital. But that's what needs, you know, what needs to be done. So also full strength. You know, are you giving full strength tube feeding or half strength? When you're giving full strength tube feeding, okay, it's going into the, you know, into the stomach or into the jejunum, and then into the gut. So it is hyperosmolar. So what is it going to pull into the intestines?
Water.
The transverse and descending. What is it going to pull in?
Water.
Water. Okay, fluids. Okay, so because it's hyperosmolar, that's where the fluid shift is going to occur. So one of the common side effects or complications is diarrhea. okay, because it pulls that water in. Now, if you have that patient and they're receiving Lasix, to be able to take off the fluid generally in the body and thereby taking fluid from the vasculature as well, what is your patient at risk for? It's getting rid of too much fluid.
Dehydration.
Dehydration. Very good. Dehydration. So that's why they need free water. So a lot of times when they hang tube feeding in one bag, they'll have a flush bag and the physician will order how much flush he wants to have over, or how much water he wants to have over a specific amount of time, say 300 milliliters every 6 hours. Okay, so definitely need free water. And then they're at risk for aspiration. So when you go in, if for whatever reason you need to put that head down to adjust them or turn them or whatever, the first thing you're going to do is stop the pump. Okay, you're going to stop the pump. You're going to get yourself together, get the patient together to get ready to move up and to turn, get as many people as you need. And then you can lay them flat, pull them up, turn them, get them situated, and put them back up to ahead of the bed, 30 degrees or greater. And then once they're settled, you restart the pump again. Okay, and that way the enteral feeding doesn't come up from the stomach and end up with GERD. Okay, and they aspirate tube feeding. Okay, and that they can end up with aspiration pneumonia. I know I ran a little over. I'm sorry, but I wanted to get finished with this for next week. Look up those exemplars. Use the nursing process. What are you going to assess for? What are you going to, what is, are the interventions you're going to do? Why are you going to do them? That's what the rationale is all about. Why are you doing something? Okay, what outcome do you want to see based on that intervention? Okay, so all of that kind of stuff, problem list, all of it going down for all of those exemplars. And then I'm going to show you how to put it on a chart on that big sheet so that you can study smarter, not harder. Okay? All right, you guys have a good clinical week.
Can I ask you a question before you go?
Sure, that's fine.
So you mentioned if it's